So without further delay, it is my pleasure to introduce our first speaker, Dr. Philip Dzwonczyk, Medical Director of Palliative Medicine at United Health Services. As a reminder, the session will be recorded for educational use at a later time. Dr. Dzwonczyk?
Thank you, Lauren. We're going to go over an introduction to palliative medicine with a tailored approach toward the population for which we care and for which we have gathered together this morning, and that is the people we care for who have developmental disabilities. Next. Yeah, during the next 50 minutes or so, I want to start with a case presentation and then present an overview of palliative care. We'll talk a little bit about the outcomes of some life-sustaining treatments like CPR, mechanical ventilation, artificial nutrition, and we'll go through some of the highlights of the decision-making process for people with developmental disabilities, which I think we are all aware is different than it is for the general population. Obviously, the other speakers today will go into that particular aspect in greater detail. And then I'll say a few things about doing palliative care in the era of COVID-19 and some of the challenges that presents to us. And then we'll talk about how we are organized as a palliative care service at UHS. Next. So our case is a case that I put together. It's a composite of many cases we've dealt with, but it illustrates some of the points which are very common in terms of their occurrence in our taking care of this population. I call this man Robert T. He's a 62-year-old man with Down syndrome and intellectual impairment as a consequence of the Down syndrome. He resides in a group home in Endicott, which is operated by a not-for-profit agency headquartered here in the Southern Tier. He's lived at this home for the last 5 years and is well known to the staff. His mother and father died within the last decade. He has a sister named Rhonda who visits him frequently and who's actively involved in decision-making regarding his medical care. Next. Over the course of the last 2 years, the staff at the home have noted a steady, gradual deterioration in his level of function. Previously, he was verbal and able to make his preferences for meals and activities known. He was able to ambulate independently and toilet in himself without difficulty. He enjoyed meals with other residents of the home and did not need assistance at meal times. About 2 years ago, the staff noted that Robert began to repeat himself. He occasionally got lost in the home trying to find his room. Having always enjoyed his contacts with staff and other residents, staff at the home were disturbed by episodes of belligerent and sometimes agitated behavior which began to characterize his interactions with others in his home. This progressed in severity, and the home staff arranged for him to see a psychiatrist who ordered an antipsychotic medication for him. Next. Robert continued to decline in function, and during the last 6 months, he's become essentially nonverbal, no longer is able to recognize staff members and other residents of the home and his sister Rhonda when she visits him. He now requires considerable assistance with feeding, cannot transfer independently, and spends most of each day in bed. He's incontinent of urine and feces, and staff members are employing adult diapers in his management. Within the last 3 months, Robert has, despite the efforts of the staff to feed him, developed significant dysphagia, and he has lost about 10% of his body weight over that time. 1 month ago, he was admitted to hospital with aspiration pneumonia, received antibiotics for this, and returned to the group home. He's appeared to get progressively weaker, and staff notes that he seems to cough, often violently, after eating and drinking. Next. Robert appears to be unresponsive and feels warm to touch. The staff call 911 and he's taken to the emergency department of the hospital. There he's found to have a temperature of 39.5. He has tachycardia and is hypotensive. His oxygen saturations are marginal and he has tachypnea. He's admitted to the regular medical floor after receiving antibiotics, fluids, and supplemental oxygen, via nasal cannula as part of the treatment for pneumonia and sepsis. An echocardiogram is performed showing that Robert has heart failure with reduced ejection fraction, and his ejection fraction is quite low at 15%. Next. The hospital service places a consult to the palliative medicine service requesting our assistance in defining goals of care for him. The palliative medicine service assesses him and arranges to meet with Rhonda to discuss the patient's diagnoses, prognosis, and the options available for his management. Unfortunately, shortly before the family meeting is scheduled to begin, Robert becomes hypotensive, dyspneic, and cyanotic. His oxygen saturations drop into the 70% range, and he's transferred to the ICU. Next. The palliative medicine team meets urgently with Rhonda. She makes it clear to them and to the nurse practitioner from the ICU team that she does not feel that life-sustaining treatments like CPR, endotracheal intubation, mechanical ventilation, and placement of feeding tubes are in Robert's best interest. During the family meeting, the palliative medicine physician receives a call from the ICU attending physician informing him that Robert's condition is rapidly deteriorating and that, if his life is to be prolonged, they must intubate the patient now and begin administration of pressors to treat septic shock. Next. So this is, as I said, a scenario that unfortunately we still see. And I say unfortunately because the case highlights some of the problems that can occur in caring for very sick people who have developmental disabilities. One of the issues raised by the case is the identification of the causes of cognitive impairment in this man. And clearly this man had intellectual impairment his entire life because of the Down syndrome. But it's clear from what we know about him that a couple of years ago he started to develop a further decrement in his cognitive abilities and most likely had developed dementia. And again, most likely this was caused by Alzheimer's disease since the prevalence in elderly Down syndrome people is high. The identification of all medical comorbidities is an important aspect of managing patients like Robert. We found out here only after he presented with his serious illness that he also had another previously unrecognized significant life-limiting illness, and that's heart failure. The implications for prognosis are quite striking, and also the role of involved family members needs to be emphasized. The patient's sister here was actively involved in his care and definitely wanted to meet with members of the care team. It was unclear in this case, but it has been my experience that many times involved family members don't know the limits of their decision-making authority for this population. It also highlights some of the problems with the legally established process for withholding or withdrawing life-sustaining treatment in patients with developmental disabilities. This is primarily because of the impact on management caused by the time to proceed through this process. So things like CPR and intubation and feeding tubes may need to be applied fairly rapidly because of the critical nature of the illness. It also highlights the emotional impact that this can have on the patient, the hospital staff, the family of the patient, the staff from the group home, and the medical providers caring for the patient. Next. So let's talk a little bit about what palliative care is. It is somewhat difficult to define. I can tell you what it isn't. It isn't a specialty that is limited to a particular body system or associated with a particular set of procedures. It's not defined by the age of the patients we care for, and it's not defined by the location of care. It is applicable to any illness at any age in any location. Next. Palliative care is an approach to care which focuses on comfort and quality of life for those affected by serious illness. Its goal is much more than comfort in dying, although that's what we spend a lot of time attending to. Palliative care is about living through meticulous attention to the control of pain and other symptoms while supporting emotional, spiritual, and cultural needs and maximizing functional status. The spectrum of investigations and interventions consistent with a palliative approach is guided by the goals of the patient and family and by accepted standards of care. Next. So my team is very used to me talking to patients and families about coming at a certain point in an illness to the fork in the road. And you can see on this slide that the aggressive care, the road on the right of your screen is disease-focused care. And that's usually the road that people have been on. And indeed, Robert, in this case presentation, is certainly on that road. But there's another road, the road that goes off to the left, that we need to acquaint patients and their families with, talk about the duration of that road, the time frame, where the care might take place, and what the patient and family might expect regarding their care. And then we go over the ways in which we and other parts of the health system can help the patient, family, and healthcare team with that. And that road that goes off there to the left is the road of comfort-oriented care. Next. So palliative care, I would argue, is highly relevant. I mean, I listed here the lifetime risk of developing certain commonly occurring medical conditions. And you can see the risk of heart disease in men is 1 in 2, cancer greater than 1 in 3, Alzheimer's, if you make it to age 85, is 1 in 5, diabetes 1 in 5, Parkinson's 1 in 40, but the lifetime risk of death is 1 to 1. Next. We've taken a look at the concept of palliative care, and the graphic on top on your screen is how we used to view this, 35, 37 now years ago when I started in this field. And we used to conceive of a period of active treatment. And then when that was finished, we would say the patient was appropriate for palliative care until they died. What has emerged as the way we conceive of palliative care now is listed here on the bottom, and it is two sort of triangles with on the left treatment being primarily disease focused with the intent of cure, and then an increasing role for palliative or comfort-oriented management as a disease process goes forward. And then, very importantly, after death, the emphasis on bereavement care. Next. So, the Dame Cicely Saunders' 4 spheres of suffering listed on this slide. And of suffering we know now is far more than just physical suffering. It involves emotional, spiritual, and psychosocial domains of suffering. Next. Effective care of the dying involves an adequate knowledge base, but it also involves an attitude and attendant behavior and philosophy, emphasizing an active, aggressive management of suffering, a team approach, recognizing death as a natural closure of life, and broadening the concept of successful care. Next. So potential palliative care interventions are listed here, and these Venn diagrams are sorted out so that on the left you can see the kinds of interventions that are generally consistent with palliative management, and on the right consistent interventions that are generally not consistent with palliative management. And in the middle, some interventions which may or may not be consistent with that. Emotional, spiritual, and psychosocial support are always part of palliative management, as are control of pain, dyspnea, nausea, and vomiting. CPR, mechanical ventilation, and highly burdensome interventions are rarely part of palliative management. Dialysis is also probably not consistent with a comfort-oriented course of management. But things like transfusions, management of infections with antibiotics, treatment of hypercalcemia, and artificial nutrition are things that we often find have to be tailored to the specific needs of a specific patient. Next. So where is palliative care delivered? And the answer is anywhere. Next. So the elements of the end-of-life experience are listed on the slide: the fixed characteristics of the patient, the modifiable dimensions of the patient's experience, the care system interventions, and the outcomes or the overall experience of the dying process. Next. This is a slide that lists the fixed characteristics of the patient: diagnosis, prognosis, their race, ethnicity, and culture, their religion, and their socioeconomic class. The modifiable dimensions are spiritual, cultural, existential beliefs, economic demands, hopes and expectations, physical symptoms, caregiving needs, social relationships, support, and psychological and cognitive symptoms. Those are the areas we can impact. Next. Then there are the health system interventions: family and friends, community, institutional interventions, and the interventions of health professionals. Next. And of course, the outcomes that we hope to influence are utilization, quality of life, satisfaction, and pain and symptom relief. Next. Palliative care involves relieving suffering and improving quality of life. Next. The Institute of Medicine got this whole specialty off the ground a long time ago. In the late 90s, they defined palliative care as seeking to prevent, relieve, reduce, or soothe the symptoms of disease or disorder without affecting a cure. Palliative care in this broad sense is not restricted to those who are dying or those enrolled in hospice programs. It attends closely to the emotional, spiritual, and practical needs and goals of patients and those close to them. Next. An expanded definition affirms life, regards dying as a normal process, neither hastens nor postpones death, provides relief from pain and other symptoms, integrates psychological and spiritual care, is practiced always by an interdisciplinary team, and provides a support system for the family. And this is, these elements come from the World Health Organization definition of palliative care. Next. Hospice, as defined here in the US under the Medicare hospice benefit, is a healthcare delivery system under which support and services are provided to a patient with a terminal illness, where the focus is on comfort rather than curing an illness. Thus, hospice can be considered a program that delivers palliative care to patients at the end of life, while palliative care can be appropriately offered to patients at any time along the trajectory of any type of serious illness, even concurrent with restorative life-prolonging therapies. Hospice is a model of palliative care that is offered to patients at the end of life when curative or life-prolonging therapy is no longer indicated. While all care that is delivered by hospices can be considered palliative care, not all palliative care is delivered in hospices. And the next slide will show a graphic representation of that. So the big blue circle is palliative care. And I make the point that not all palliative care is hospice. Hospice care is a subset of palliative care. All hospice care is palliative care. So hospice is the particular subset of palliative care that delivers with caring for people at the end of life. And in our country, Medicare defines that as the last 6 months of life. Next. So comfort care is a term we use a lot, and it refers to a set of the most basic palliative care interventions that provide immediate relief of symptoms in a patient who's very close to death. These measures are used to achieve comfort for a patient fairly rapidly. Diagnostic or therapeutic maneuvers that might be considered appropriate for palliation in earlier stages of the illness usually are not considered in this context. Next. So why are we focused, as we are at UHS, on raising the level of skill amongst providers and other health care professionals who work in the hospitals? Because hospitals remain a major site for end-of-life care, even though a growing proportion of deaths in our country occur at home and in nursing homes. The last time this was quantified was 10 years ago, and 29% of deaths occurred in hospital. The average terminal admission lasted almost 8 days. Next. Multiple distressing symptoms can affect hospitalized patients who have advanced life-threatening illnesses. Some of the symptoms worsen as the patient approaches death. Poorly controlled symptoms occur in patients with advanced cancer, heart failure, chronic obstructive pulmonary disease, and many other life-threatening conditions. That emphasizes the importance of meticulous management of these distressing symptoms near the end of life, where they become, in fact, the primary focus of our intervention. Next. Palliative care services can reduce the distress caused by symptoms and improve the quality of patients' lives near the end of life. Some of the challenges to achieving this include a scarcity of palliative care specialists. There is a workforce shortage that is projected to continue far into the future. The responsibility, therefore, for ensuring excellent end-of-life care for dying patients currently falls primarily on generalists and in specialists in areas other than palliative care, people like oncologists and cardiologists. The familiarity with basic comfort measures is an essential skill for all clinicians who care for patients near the end of life. Next. The broad goals and methods of comfort care near the end of life should reflect the informed patient's wishes. For people with developmental disabilities, the goals and methods need to be in the patient's best interest, since for this population, they may not have ever been able to tell us what their preferences were. Next. Communication techniques that can be used to help terminally ill patients identify their values, goals, and preferences. It is very important to begin these discussions early in the illness. Please don't wait until a medical crisis occurs, like we saw in that case presentation at the beginning, where the discussion with the patient's sister was going on literally as the ICU team was getting ready to intubate him. Or where death is imminent, revisit these discussions when the patient's condition changes substantially. So if we think back to that case presentation that I began with, and again, recognizing that the process of navigating all of the legal requirements for withholding life-sustaining treatment in developmentally disabled people, we should have recognized that something was happening with Robert 2 years prior to that ICU admission, because that's when the staff at the group home really began to notice the development of another syndrome, a syndrome of dementia, with further decrement in cognition. And that, ideally would have led to the identification of the etiology, and then that could have led very early on to an exploration of the goals of care for Robert with his sister Rhonda much earlier than in the crisis atmosphere in which, in our case presentation, it was taking place. Next. So the main features of approach to care are perceptive and vigilant approach to regarding changes in the clinical status of the patient, proactive communication with the patient and the family. We try to anticipate questions and concerns. We try to be available. And we always try not to present non-choices as choices. An example of that is someone with an advanced cancer for whom there is no established medical chemotherapy intervention which will likely alter the course of the disease at that point. We need to be aware when we present choices to a family what the realities of the choices are, so that families, many of which are fairly unsophisticated in their medical knowledge base, don't misperceive options as being available which really aren't. We always are aggressive about pursuing comfort, and we try not to be caught off guard by predictable problems because that can damage our relationship with a family. Next. What are those predictable challenges in the final days of life? Well, functional decline is a predictable occurrence. Increasing dependency in transfers and toileting, difficulty swallowing medications, so we have to be aware of other routes of administration of medications, the development of terminal pneumonia and its attendant dyspnea, congestion, and delirium. In some studies, as high as 80% patients with terminal pneumonia will develop delirium, and at times they can become agitated. We also know that the concerns of family and friends can be part of the presentation of predictable challenges in the final days of a patient's life. Next. What are the concerns of patients, family, and friends? Well, how could this be happening so fast? We hear that a lot. What about food and fluids? You know, things were fine until that medicine was started. Isn't the medicine speeding this up? You know, and that's a misperception about our opioid analgesics that we hear all the time. Too drowsy, too restless. Confusion, he's not himself. We've lost him already. What will it be like? How will we know when the end is near? And then the concern that we've missed the chance to say goodbye. Next. And this is a little graphic that kind of perceives sometimes how our patients, and more often their families, perceive this. So when reserves are depleted, the change seems sudden and unforeseen. However, the change, had been happening, and it's this happy face on the melting ice with diminishing reserves here on day 1, day 2, day 3, and then when the ice gets thin enough, we're into the water, and the perception is that occurred very fast, that it occurred very rapidly, when in fact it's a process that had been slowly and inexorably progressing over a longer period of time. Next. One of the topics we are presented with by families as a concern all the time is food and fluids at the end of life. We always have to return to the goals of care discussions that we've had with patients and their families, and discuss artificial nutrition, or discuss nutrition and hydration in general in the context of the goals that were established for the patient. We try to distinguish between prolonging living and prolonging dying. We make the point that parenteral fluids generally do not improve the comfort level of patients at the end of life, and that pushing calories in the terminal phase of life does not improve function or outcome. Next. So the dying process should never entail sustained severe pain or other physical suffering. That's one of the core principles of palliative medicine. We need to assure the patient and the family of the patient that comfort is a very high priority for us, and that troubling symptoms will be expertly treated. Next. We involve our interdisciplinary team because that team can offer comprehensive coordinated care for the patient and the family. It is essential to work as a team that allows us to promote good communication among the team and good communication back to the patient and their family. Next. Nursing interventions can be critical in addressing the full range of the patient's and the family members' needs, emphasizing good oral care, skin and wound care, and the application of heat or cold packs to alleviate discomfort. Attention from mental health providers can be quite useful, and our team works with the psychiatry staff at UHS frequently. The role that social workers, music therapists, and volunteers play cannot be overemphasized. Next. We always take a spiritual history. We always inquire about the needs of the patient in terms of their spiritual or religious needs. A simple question, was religion important to this patient? Can be very helpful. Did this patient have a faith tradition or belong to a church or temple? That can be very useful. And we offer chaplaincy services when appropriate. And we, on our team, work very closely with the chaplains at UHS. Next. One of the roles that we play is a role of de-prescribing. We discontinue diagnostic or treatment efforts that are likely to have negligible benefit or that can cause harm by diminishing the patient's quality of life or his or her ability to interact with loved ones. Some of the things we stop when patients elect a comfort-oriented plan of care are the monitoring of vital signs, which really are not terribly useful in the vital days of life. And this, taking vitals is now done with a lot of noisy, distracting machines and can interrupt sleep. We also stop unnecessary medications not intended for comfort. One example that I highlight here are the continuation of statins for hyperlipidemia, which really doesn't make sense in the context of a life that's going to shortly come to an end. Provision of mouth and skin care and changing the patient's position in bed can enhance comfort in some situations, but in other situations, these measures can bother the patient. Repositioning can be painful, and so they can contribute to suffering, and they should be discontinued. And this point highlights the fact that this is not a one size fits all approach. This has to be tailored very specifically to the needs of each patient. Next. We encourage oral assisted eating for pleasure, respectfully informing patients and family that the administration of intravenous fluids and nutrition through a feeding tube has no benefit in terms of comfort or survival during the last days of life. Next. We always try to inform the patient if they're still able to process this information, and also the family about any proposed major changes in the management of the patient's condition. Next. We consider home care rather than care in the hospital for the patient if appropriate. Most dying patients are more physically comfortable at home. Family members have generally been found to be most satisfied with the experience of relatives who die at home with hospice care. That said, some of the changes in our society that have occurred over the course of my career in medicine have made it less likely that there will be an ability to care for a patient at home. Next. So I want to talk a little bit now about the outcomes of life-sustaining treatments, and I'll begin by going over CPR survival in the hospital setting. Next. CPR for hospitalized patients is associated with poor outcomes. So CPR doesn't work very well for people who are really sick. The cause of arrest is usually associated with advanced chronic illness rather than an easily reversible acute cardiopulmonary event. Factors predicting a failure to survive to discharge after CPR include sepsis on the day prior to the CPR event, a serum creatinine greater than 1.5, metastatic cancer, dementia, and dependent functional status with impaired activities of daily living, something that factors into our assessment of the degree of medical frailty that a patient has. Next. Roughly 15% or 1 in 6 patients who undergo CPR in the hospital may survive to discharge. That's really not a great success rate. Specific comorbidities reduce the chance of survival further, as we mentioned in the last slide. And surviving patients are at risk for a long list of CPR-related complications, such as permanent neurologic impairment, with impairment of alertness and cognition, and permanent functional impairment. Next. So there's a lot of inaccurate information about CPR and CPR outcomes out there for the public. They have an inflated perception of CPR success. Most people believe that CPR works 60 to 85% of the time, when, as I've told you, the actual survival to hospital discharge for all hospitalized patients at best is around 15%. And it's lower for elderly patients and those who have serious medical comorbidities. So it's around 5% or less for that subgroup, which is a large subgroup. I mean, it must be said that the vast majority of consultations that we do in the hospital involve elderly patients with multiple serious medical comorbidities. So this is a time to review and clarify the indications, contraindications, potential outcomes, and morbidity of CPR. A good way to get started is to ask the patient what they know about CPR. Next. So again, more outcome information about CPR in terms of all sites, unwitnessed arrest, asystole, EM dissociation, prolonged resuscitation, metastatic cancer, multiple comorbidities, sepsis, and seriously ill patients who would be appropriate for most medical orders for life-sustaining treatment discussion are associated with poor outcomes. Next. Public perceptions are greatly influenced by the mass media. On television, 67% of resuscitations are successful. And so we really need to educate our patients. And we found that decisions regarding CPR change significantly after families and patients are reoriented to the reality of the outcomes data. And there's also misperceptions about what we're talking about. The vast majority of people don't know that you need to be on a ventilator generally after resuscitation. 37%, that's more than a third, thought ventilated patients could still talk to their families and friends. 20% thought that ventilators were oxygen tanks. Next. DNI orders are also very important because for medically frail patients, there is a high risk of prolonged mechanical ventilation, which may lead to tracheostomy and to a limited choice regarding skilled nursing placement. Next. Artificial nutrition and feeding tubes are also a topic we address. We usually talk to people about the realities of needing a PEG tube or a J tube rather than the nasal or orogastric tubes. As you know, the latter two approaches to artificial nutrition really are only useful temporarily. They're not a permanent destination therapy. Patients with advanced dementia are an important group for whom these discussions need to occur. We do not recommend feeding tubes in patients with advanced dementia. Instead, we offer oral assisted feeding. And at this point, all of the organizations that advocate for effective care for the elderly, and especially for those of us who care for those patients, support this approach. And this would include the American Geriatric Society, the American Medical Directors Association, and the American Association of Hospice and Palliative Medicine. Next. Feeding tube use does not result in improved survival. It doesn't prevent aspiration pneumonia or improve the healing of pressure ulcers. It is associated with pressure ulcer development. It is associated with physical and pharmacological restraints, and it causes distress about the tube itself with infection at the site and pain at the site. Next. So in patients who have developmental disabilities, there's a need for early identification of the patients who are in need of advanced care planning because our public health law specifies specific processes for developmentally disabled patients. These processes are more involved, they take more time, and there's a lot of risk of adverse outcome associated with waiting until a developmentally disabled patient is really sick and for whom decisions about life-sustaining treatments are urgent. And I've listed some of them here. Next. Goals of care discussions during this era of COVID-19, especially for patients who have that disease and who are ventilated, is fraught with many challenges. You know, I'm going to really boil this down. You can look through the slides yourself in greater detail later on, but I want to emphasize that one of the real problems in working in the COVID-19 era is that communication between us and families can be quite difficult and limited often limited to a phone call, so that we're only doing voice and not even they're not even able to see us. In patients who are developmentally disabled, the patient may not have decision-making capacity, even if they previously had it, because the nature of this illness often results in them being ventilated. Care preferences may not be known. They may not have a healthcare proxy or a 1750B surrogate decision maker, and the family may not be able to come into hospital or come into the part of the hospital where they're being cared for to visit. Doing this over the phone can be awkward and far from ideal. Next. So we'll go to the next slide. So we try to do this early, and I want to emphasize that over and over. Forecast potential outcomes, prepare the involved decision makers for difficult decisions that may be up ahead, try to identify a surrogate decision maker early in the hospitalization, and screen that person's preferences for potential use of CPR and mechanical ventilation, because we know that this is a high likelihood situation. We identify patients who are at risk for poor outcomes. The sequential organ failure assessment score can be useful here, as well as simply outlining the medical comorbidities that the patient has. And then trying to tailor always our recommendations regarding CPR and mechanical ventilatory support to the individual patient and their needs. Next. Let's move on over this slide to the next. And the next. We'll move ahead. So COVID-19 is a serious illness that can be deadly. It is difficult to forecast, yet reversible in many hospitalized patients. The difficulty with this illness is that things can change very quickly, suddenly, not giving family members much time to deal with what's happening. And also the illness itself, because it requires the patient to be isolated, may significantly limit the choices that are available to a family regarding the preferred end-of-life setting. Next. So a suggested approach here is to acknowledge and normalize the urge to focus short-term on how to survive the illness, but offer early advanced care planning targeted to the acute situation. Do they have a surrogate? Do they have a healthcare proxy? Would they find intubation or ventilatory support acceptable if it was needed? And are they aware of the realities of outcomes of CPR? In other words, hope for the best, but prepare for the rest. Let's move to the next slide. And I'm going to skip through these, and you can look at these. There's several slides. So let's go to the next one, and the next one, and the next one, and the next one. So how are we organized here at UHS to deliver palliative care? I've listed on this slide the principal people that you will deal with if you come in contact with our service. Chris Marks is our administrative director. I'm the medical director. We have 2 full-time nurse practitioners, Wendy Zawia and Becky Dickman. And our social workers are Amy Alonzo, who many of you know, and Emily Tier. Our nurse, who, by the way, answers the phone when you call our office, is Lauren Heckman. And our departmental administrative assistant is Lori Tyler. Next. Currently, we provide consultative services. We run an inpatient consult service that is very busy at Wilson and Binghamton General Hospital. And we see outpatients in clinic settings in Binghamton, across the street from Binghamton General at the Summit Building, in Vestal on the Parkway, at UHS office in Endwell, and also at the Johnson City site of Broome Oncology, and radiation oncology, I should say. We also, beginning with the COVID pandemic, started to do virtual outpatient visits, and we have done quite a few of those. So I would add that as another location where we see patients now. Next. Contacting us is pretty easy. You should call us. We are available between 8:30 and 4 on a Monday through Friday basis at 763-6982. If we're not in the office when you call, there's voicemail on that line and someone will call you back. Next. So I want to thank you for your attention as I've given this talk. I have to say it's a little different doing it this way through a Zoom platform rather than being able to see you all in a classroom or a conference room setting as we usually do this. And I believe we have 10 minutes to field some questions. So I think the way we're going to do this is Lauren Greco is going to send those questions up to me and I'll do my best to answer them.
Hello. So, I am in normal Friday morning fashion. We have a few technical difficulties, so you can't. Can you see me, Dr. Dzwonczyk?
I cannot see you. I am seeing Laura Bavacqua's name, and I'm not seeing you.
Okay. Well, we're gonna just go ahead. Maybe my camera will come back on. It's actually better for me that it doesn't. But we do have one question, so I'm going to present that to you, Dr. Dzwonczyk. In the meantime, if any of our other participants have questions, you can ask that using the Q&A box right at the bottom of your screen. So our question that we have is from Cindy at SDMC. And Cindy says, we sometimes find that staff have a gut instinct that a proposed treatment would not be in a person's best interest, but they lack the ability to articulate how or why. Could you expand on the spheres of suffering model or give other examples of care burdens beyond pain?
So it sounds like that's a two-parter. Yeah, the first part where the staff caring for somebody who is coming to the end of their life is being subjected to interventions that, you know, have the downside of increasing suffering, and the staff are aware of that, but can often experience frustration, either because they have difficulty in communicating that to the decision makers, or often they may have difficulty communicating with other parts of the healthcare team, often my colleagues. That's actually an example of a role that our team plays on an almost daily basis at UHS hospitals. We can be helpful in bridging a communication gap between, say, the nurses caring for a patient and the attending team managing the patient. We can be useful in trying to build a bridge between the reality of the patient's medical situation and the likelihood of a prognostic outcomes and the family's perceptions and beliefs. So I would say the answer to the first part of that question is consult palliative medicine in whatever hospital you're working, and they can generally help with that. And I'm choosing my words carefully because obviously we don't always succeed, but I think that it is a useful role that we play in working with people in this regard. Now, in terms of the second part of the question, which was, you know, a request that I expand on the four spheres of suffering. And I said on an earlier slide that in addition to physical suffering, you know, which is pain and the non-pain symptoms like nausea, shortness of breath, and you can go on and list quite a few of these, there are other domains of suffering that are just as important. And the psychosocial sphere is one of them. Spiritual suffering is also part of this, and emotional suffering. These areas are all knitted together in an individual patient. And one of the things I think pretty much every palliative medicine specialist learns is that if you don't, to some degree at least, address these, you will be less effective in controlling, you know, the physical symptoms of suffering. Sometimes the key to improving the quality of life for a patient who's coming to the end of their life with a serious illness has less to do with your expertise in prescribing medications than it does in terms of your ability to relate to that person and ask the right questions to uncover unresolved issues in the psychosocial sphere, in the emotional sphere, or in the spiritual sphere. You don't need to be a professional expert in all of those areas, but you do need to work as a team, which is why palliative medicine is practiced as an interdisciplinary team. I'm very fortunate to work with nurses and social workers who are very expert, and we have a strong chaplaincy corps at UHS, which can help us with the spiritual side of things very much. But if we don't at least ask the right questions, we won't be as effective in managing suffering and raising the functional level and comfort level of a patient as they come to the end of their life. I hope that answered the question.
Thank you, Dr. Dzwonczyk. I'm not seeing any additional questions in our Q&A. So this is just a reminder to the audience. If you have a question, you can ask it at this time. Dr. Dzwonczyk, Cindy says yes, that answered her question. Thank you very much.
Good. So maybe you could go to the next slide because it lists some of the references. And since we don't have a lot of questions, I can just point out a couple of these references that I think are really important. So that the first reference on this slide, the article by Blinderman, Billings has really become a core. We use this article for residents when they rotate on palliative medicine and medical students, and it's really very well written, and I'm able to access it just by going to the New England Journal of Medicine site and download the PDF. It's not restricted, so you don't need to subscribe to the journal to get it. Next. The other reference group really that I'll list here are a series of articles that I pulled off the FACP website. The web address is listed here. FACP are a very useful source of information about all topics in palliative medicine, and I recommend that. These are the ones I used for this talk, but really it's indexed and searchable. And so if you're dealing with non-surgical management of bowel obstruction at the end of life, you can search for that and come up with a short article that highlights the approach and then is referenced if you want to read more about it in greater detail. Next. And these are this was a talk that's also posted on my Palliative Care Now website, from which I get the slides about dealing with decision-making in the era of COVID-19.